Welcome to today's webinar. We are beginning shortly as we anticipate attendees to enter the room. Welcome everyone to today's webinar. My name is Jose Francisco, Project Manager at the IAS USA. Today's webinar will explore the latest update to the sexually transmitted infection treatment guidelines. I'd like to welcome our presenter, Dr. Workowski from Emory University. Welcome, Dr. Workowski.
Thank you so much, Jose. And I wish I could see all of you in person. But I wanted to share some important information about some of the updates from the STI treatment guidelines, as well as provide you some information about current epidemiology and some of the current controversies that we're encountering at this point. So just to remind everyone that this webinar is eligible for AMA CME credits, as you see down here on your slide. And instructions for claiming credit are on the ISA website, and you see the credits that it's been approved for. And I want to thank the contributors for their contributions to this webinar. Very important to have them supporting this effort. So a little bit in terms of navigating the webinar. I'm going to give you some poll questions. A separate window will show up, and then you're going to have a response to the poll. What I'm going to do is I'm going to give you a couple of pretest questions, and then we're going to look at those at the end. And then I'm going to give you an interesting case that I just saw. And you can hold your comments to the end, but we're going to try to talk about what the potential etiologies are of this patient I'm going to show you. So for the first poll, how many times have you diagnosed a sexually transmitted infection within the past month? And we'll wait for a response here and then we'll move on. I don't have any beautiful music. I was going to do that and I forgot that we normally do when we're all in person. So maybe if you just hum a little bit, that's fine with me. So we have quite a mix of people, which is great. So hopefully you're going to take something away from some of this information I'm going to give you. So our first pretest question for you. This is a 19-year-old woman who presents to the student health center at college to discuss birth control options. She's got no complaints. She's had 2 male partners in the last 6 months. She practices receptive vaginal and oral sex with male partners and is inconsistent condom use. In addition, discussing options for birth control, her provider recommends diagnostic testing for chlamydia and gonorrhea versus a self-collected vaginal swab. Subsequent testing reveals a negative pregnancy test and a positive chlamydia test. So which of the following is correct regarding the management of her chlamydia infection? Doxycycline and azithromycin are equivalent regimens for her chlamydial infection. Detection of rectal chlamydial infection should only be considered in women who engage in receptive anal intercourse. The most frequent clinical manifestation of chlamydia in women is intramenstrual bleeding. Test of cure 4 weeks after completion of therapy is recommended at completion of therapy, or repeat testing at 3 months is recommended regardless if sex partners were treated. So I'm going to give you a moment to think about these. You can answer a question and then we'll discuss your answers at the end. So a number of you have a number of different answers, so we'll talk about these as we talk about chlamydia. Next question. Next question is a 23-year-old man who presents with purulent discharge. He is sexually active with multiple partners. His sexual practices include receptive and inserted oral and rectal intercourse. He was evaluated 1 week ago and treated empirically for non-gonococcal urethritis with 1 gram of azithromycin. Chlamydia and gonorrhea testing by nucleic acid amplification test was obtained at initial presentation and was negative. Physical examination is notable today for urethral discharge. His first void urine also demonstrates greater than 10 white cells per high power field. Which of the following is true regarding the etiology of persistent or recurrent non-gonococcal urethritis? Trichomonas can cause urethritis in men who have sex with other men, likely acquired through receptive anal intercourse. Neisseria meningitidis has a similar colony morphology appearance on culture and cannot be distinguished from Neisseria gonorrhea on gram stain. HSV2 is a more common etiology of urethritis than HSV1. Associations between urethritis and insertive anal and oral exposure have been reported with Lepotrichia snethia species. Mycobacterium genitalium urethritis has been associated with chronic complications among men, including epididymitis, prostatitis, or infertility. Be interested in these responses. So this is again getting at your knowledge regarding recurrent non-gonococcal urethritis. Thank you for those responses. We'll talk about this and then you can take your pretest and see if your response got better after this webinar. So thank you for responding. So let's first start by talking about our current state of STIs in the United States. This is data from the most recent CDC surveillance report in 2019 that shows for the 6th year in a row, we continue to have very high rates of chlamydia, gonorrhea, and syphilis, our reportable STIs. And one of the things really that I want to take from this slide is that the dramatic increase we're seeing in heterosexual syphilis among women. And we'll look at some graphs, but this is really dramatic. And we continue to see a dramatic increase in congenital syphilis. As most of you know, the CDC produces a surveillance report once a year. And this is the most recent data we have. And unfortunately, we only have a digital version of this, but you can go online to get more granular in terms of these numbers. So what are the consequences of STIs? Well, in terms of the United States, it's about 16 billion in direct medical costs. We know about 1 in 5 people in the US have an STI. And we know that there are certain populations that are more disadvantaged than others in terms of acquiring an STI. About half of our STIs are in our youth, aged 15 to 24. Also wanted to mention in terms of consequences, we know that STIs have consequences, both reproductive consequences, development of malignancy, and also increased risk of HIV acquisition. And the data that we have on the STIs that cause this the most in terms of increased risk is syphilis, primary and secondary syphilis, and gonorrhea and chlamydia rectal infections. And these were just showing several studies showing that the acquisition of rectal STIs or syphilis and the percentage that were diagnosed with HIV within 1 year. Also, we know that individuals that take post-exposure prophylaxis should be tested for STIs every 3 months. And this is just a recent meta-analysis looking at the increase in rectal STIs of individuals that are on PrEP. So most of these infections are asymptomatic. So what I would recommend is that you continue to follow the recommendations from the CDC on PrEP, and there are some revised guidelines that should be available. They're forthcoming in the next several weeks to months. So I've shown you some dramatic data in terms of surveillance. We talked about the consequences, but what are our current challenges? Well, I think the current challenges have really been borne out well in the issues of COVID, where we've had issues with clinics closing, the issues of telehealth not being able to examine patients. We had antimicrobial shortages. Remember when azithromycin was recommended initially with hydroxychloroquine and nobody could find azithromycin. We've had swab shortages. We continue to have incredible disparities, both racial and ethnic disparities. There's geographic disparities, age disparities. There's the stigma that surrounds STIs. Most STIs are asymptomatic, so we have to do a behavioral and biologic risk assessment. We have to know about the atypical presentations, which I'm going to go over some of the interesting things that we've recently seen. We have limited diagnostics at the point of care. We don't have a way to quickly diagnose the etiology of urethritis, cervicitis, or genital ulcer disease. We've got increases in antimicrobial resistance, both for gonorrhea and Mycoplasma genitalium. We miss sometimes the opportunity to vaccinate individuals that have vaccine preventable STIs, including human papillomavirus, hepatitis A and B. And then we have this syndemic ongoing of STIs, HIV, viral hepatitis, and substance use disorder, where all these entities are kind of entangled and overlapping. So one of the things I wanted to make you aware of that came out last year was the National Strategic Plan that really tried to define a way forward. Just like we have a strategic plan for HIV, viral hepatitis, we now have an STI plan. There's actionable items. There's 5 goals. And within these 5 goals, if you go to the website, there's again, actionable plans. There's talks about public and private partnerships and how to really think about our impacted populations, which include adolescents, men who have sex with men, pregnant women. And this report really focuses on 4 STIs, chlamydia, gonorrhea, syphilis, and HPV. So I don't have time to discuss this. I just wanted to make you aware that there's actionable plans. So in terms of what kind of tools do we have for prevention and management? Well, CDC has published management guidelines. Actually, they started in 1972, initially started as guidance for treatment of gonorrhea and have morphed into evidence-based guidelines, which really became more robust at the beginning of the early 90s. What I list for you here is the most recent version of the guidelines, the table of contents. But what I also want to mention here is also what's on the CDC website is tables of evidence that contain all the Excel spreadsheets that contain all the evidence that drove these recommendations. And then the little QR code to remind me to tell you about an app that's going to be available soon for Androids and Apple phones that you can download a more condensed version of the guidelines to your cell phones. The other thing that you may not be aware of is CDC published in 2020 quality service guidelines. And these kind of interdigitate with the treatment guidelines. And these just really, truly talk about what you should do in whatever setting you're in. I want to thank all the folks that sent in a number of questions, and some of those I'm trying to add into this presentation. But one of the things that came up was, what should I test for? How should I test? What should I have in my clinic? What if I'm constrained in terms of resources? And so this is a really good document that talks about whatever setting you're in, if you're doing primary care, if you have access to more specialized tests, what you should really have available in your toolkit. And it assists with clinical operations of either of your operation setting, whether it's an ER or a primary clinic or a more specialized clinic. And it really provides a framework for optimizing care. So let's get started and think about what our role is as clinicians. what should we do in terms of thinking about the bigger picture for prevention? So I mentioned that most STIs are asymptomatic, and so we have to take both a biologic as well as a behavioral risk assessment. What you see on the right-hand side of the slide is the 5 Ps approach for getting a sexual history. And these have been revised a bit. These are right from the guidelines, but I would look at those and think about the questions that you ask about practices, partners, protection, pregnancy intention, and that kind of helps you frame your discussion with your patient. Also, this should be thought of in the same way as getting histories for alcohol, drug, tobacco, depression, intimate partner violence. Part of our normal history taking that we take is to think about both the biologic and behavioral risk assessment. Think about vaccination, the prevention using condoms, PrEP and PEP. We'll talk about those both for STIs and HIV, partner management, and the importance of reporting either through your state or your local health department. So in terms of the screening document, the screening part of this, the STI management document is not a screening document. There are some sections that we use for screening. One is for men who have sex with men. There are particular recommendations for who should be screened and the frequency of the screening. The other recommendations for chlamydia and gonorrhea are also included in the United States Public Service Task Force guidelines. And just several months ago, we just had new guidelines come out on chlamydia and gonorrhea. They haven't changed much since 2014, but I just wanted to put them up here to make sure that you're aware. So for women, for gonorrhea and chlamydia, women under the age of 25, because the incidence of chlamydia is the highest in that age group, and then older women at increased risk. And those increased risk are clearly defined in the treatment guidelines. The preferred specimen is a self-collected vaginal swab. And for the first time, there's some permissive rectal testing that is basically on, will be a decision between you and the patient with shared decision-making. And we'll talk about why that's important, especially with chlamydia treatment. HPV, which I'll share with you some important updates in terms of cancer screening, some nice tables that were created, and then some in trichomonas, really the recommendation is for screening, vaginal screening for asymptomatics in women that have HIV infection. And then women at high risk for trichomonas with those risk factors defined in the guidelines. As you see in the middle, men who have sex with men and the importance of extragenital testing because of the increased prevalence of infection, and the frequency of the screening is really based on risk. And then men who have sex with women to consider chlamydia and chlamydia screening in high settings. We don't have population-based screening guidelines for heterosexual men. So in the first part of the STI guidelines, we talk a lot about what you should do for behavior and biologic risk assessment, the screening for chlamydia, gonorrhea, and syphilis. And in pregnancy, there's a whole pregnancy section, but what's new in this part of the document is the importance of syphilis testing 3 times in pregnancy. There was already recommendations for prenatal testing, but now for testing at 28 weeks and delivery. For vaccination, there's a section on HPV, hepatitis A and B. Prevention methods are discussed both for condoms, circumcision, emergency contraception. All those sections have been updated, and I unfortunately don't have time to go into them. But what I wanted to tell you about was there's also, besides the HIV pre-exposure and post-exposure prophylaxis, there's a section also on STI pre and post-exposure prophylaxis, which we'll talk about a little bit on the next slide. Also, multi-purpose prevention technologies, that is combining contraception with STI prevention, is also discussed. the importance of retesting for chlamydia, gonorrhea, and trick 3 months after therapy. And then under the partner services section, we talk a little bit more in depth about expedited partner therapy, which had been there before in heterosexual men and women who had chlamydia or gonorrhea. But now the way that this needs to be framed really is as a harm reduction strategy. And also we have some language in there for more permissive language in men who have sex with men who have either chlamydia or gonorrhea. So I would refer you to that section of the guidelines to get more information. So what I had previously mentioned about STI as potential, are we looking at both, is there any studies looking at both PEP or PrEP for STIs? There has been some precedents. There have been some studies looking at both pre-exposure and post-exposure prophylaxis looking at doxycycline, but I wanted to show you the results of this paper that kind of compiled the data where studies are underway. And there have been some very interesting editorials talking about the pros and cons of using this kind of approach, both for post-exposure and pre-exposure prophylaxis. But I mentioned here that there are these 5 ongoing studies to try to better define and answer, is this a feasible option in certain patient populations? So our first ARS question, this is a gentleman I saw a couple of months ago who is 62 years old with HIV infection, who is virologically controlled. He presents because he felt this lesion around his bottom. He is sexually active with several male partners and engages in receptive anal intercourse. His exam is normal except for this painless perianal lesion. Which diagnostic test should be used to establish the diagnosis? Herpes PCR, a dark field microscopy, treponemal EIA, gonorrhea or chlamydia gnat, or a lesion biopsy? And I'll tell you that we'll talk about this at the end. But I wanted to give you an opportunity when you're looking at this, if this patient presented to you, what test would you order to make the diagnosis? So most people, it looks like we're going for a treponemal EIA. They're thinking about syphilis, and the next most common was lesion biopsy. So keep those in mind. And we'll tell you at the end what the answer is. So let's first start with genital, anal, and perianal ulcers. Even though I'm starting with this, I'm showing you a picture of somebody's mouth for a reason. The most common etiology of these are either herpes or syphilis as the most common infectious cause. We really need to think of the area you live in and the population you're serving. In particular, do you serve a population that has a high amount of syphilis? The diagnostic evaluation that we have is either dark field scope, if available, for syphilis, syphilis serology, or an Hsv nucleic acid amplification test. Chancroid is pretty uncommon in the US at this point, and what we put in the guidelines is there's a non-sexual cutaneous ulcer presentation that we wanted to make sure that you were aware of. And also granuloma inguinale can present as ulcers, but it's very common, very uncommon globally. So I have this picture up here to show you that things can present atypically. So what I show you here is a gentleman with, you see the ulcer on the mouth, and if you on his lip, and if you look closely inside the mouth, you can see on his tonsils, he's got this exudate. So I can tell you that, again, thinking that STIs traveled together, this gentleman, what I had done in this evaluation is I took a Hsv PCR of his lip, which was positive, cultured the back of his throat, and also did a syphilis serology. So the only manifestation he had of syphilis was his exudative pharyngitis, which you see there is enlarged tonsils, which were completely asymptomatic. And the lesion was positive for HSV. So this gentleman had both herpes on his lip and primary syphilis in his oropharynx. So let's first move to genital herpes and what's new in terms of the diagnostic realm. The preferred diagnostic test, if you have availability, is the HSV PCR, which is much more sensitive than culture. Culture is still useful, especially in instances of acyclovir resistant herpes. When do we use type-specific serologic testing? So the problem with the currently available serologic tests is that it has problems with test both sensitivity and specificity. That is why there is not universal recommendation for testing, population-based testing. So the recommendations are who to get type-specific testing include those that have recurrences with a negative PCR or culture, those that have signs but no positive lab test, and in instances with a partner with genital herpes. So what's new in this version is there's a little bit more discrimination if you are going to do serologic testing because of the problems with the test performance, how best to interpret the serology. So I'm not going to read what I have written down here, but the point is that we're now recommending, especially if you start with an EIA assay, the currently available type-specific assay that most people use in the US is a Herpes Select. If you get a result with a low index value, you're going to want to confirm that with a second test. The second test is either a BioKit or a Western blot. So that's what this language is about here, is that you really is trying to be a little bit more certain about the diagnosis by doing a serologic two-step testing if you are to use serology. There's also new sections on counseling for patients that have both that have either genital or oral herpes and how best to counsel them. As you know, HSV1 is an increasingly common cause of genital herpes, and we've added a section on herpes hepatitis. There's really no change. There's no new data on antivirals and no changes in antiviral treatment in pregnancy. But what I did want to mention for acyclovir resistant herpes, what you see here is a number of different presentations. On the left, what you see is a natal cleft with a knife cut lesion. This is a elderly woman with an underlying immunocompromising condition, not HIV, that ended up having this recurrent lesion in her buttock. The other lesion here is a woman with a acyclovir resistant herpes lesion in her vulva. And these are not patients without HIV. And what you see down here is a scalp lesion on the knee due to herpes. And the reason to bring this up is the presentations can be atypical, especially in immunocompromised patients. And to bring your attention to what do we really have to treat these infections? We can compound cidofovir and make a topical ointment. We can use a miquimod on small areas, but you have to be really careful, especially in areas that are really big, because these type of agents can cause burning and they can cause ulcerations if applied outside the area of the ulcer. We've got IV foscarnet, and I also wanted to make you aware of a new drug, pratelivir, which is under investigation. This is, you see a poster that was presented at ID Week. Here's the poster number, but wanted to make you aware of the dramatic results with this oral inhibitor, this oral drug that was, we've had dramatic results in the phase 2 clinical trial that's now moving to phase 3. So if you're interested and want more information, want to know what sites have this available, I've got the NCT number there that you can read a little bit more about it and what this is all about, and look at the poster for ID Week to look at the results from this medication. Next, I'm going to move to syphilis. talk about the epidemiology of syphilis per the most recent CDC surveillance report. And what you see here on the left is the male to female ratio has gone down because the female rate has dramatically gone up. The rates continue to go up. And again, what I've previously mentioned is this syndemic we're seeing between drug use, in particular meth, heroin use, and increase in heterosexual syphilis. As a consequence, this is what we're seeing in congenital syphilis, which has just been very dramatic over the past several years. What is really happening with congenital syphilis? It's kind of all over the board. There's about a third of patients that don't get prenatal care in time. I think what thing is more disturbing for me is that no adequate treatment despite a syphilis diagnosis, 30%. And so there's not one clear instance that this is happening, but wanted to bring this up to your attention because this is increasingly becoming a problem. The other problem that we see with syphilis is the dramatic presentations that are so different. What I put on this slide is the number of pictures and the presentations that are just awe-inspiring in terms of the different ways that syphilis can present, either a flat-like lesion, multiple lesions. There's a case report in the literature present now with a syphilis that was due to persistent non-gonococcal urethritis, diagnosis made by PCR. You see the finger here from a human bite. This is another patient you see in the middle with secondary syphilis with, again, one of the manifestations was bilateral pharyngeal ulcers. The alopecia, the rashes can be very different. And so it is can be very confusing. And again, we don't have a good point of care test. The other thing about syphilis is that this report came out a couple of years ago, but I'm seeing it more in my practice, is that the anal lesions are much more painful. And this was a report from towns in Australia showing that about 49% of primary anal or genital lesions were painful. And almost 40% were multiple lesions, and only 8% had concurrent herpes. So again, syphilis can be painful. And if it's gone on for a while, it can also be secondarily infected with bacteria. Also wanted to bring up the neurologic and ocular complications. So remember that when even in primary and secondary syphilis, syphilis disseminates, you can have early neuroinvasion. In most instances, it resolves spontaneously, but it can progress to either meningitis, meningovascular syphilis, which can manifest as a stroke, tabes dorsalis or general paresis, and HIV infection can accelerate this progression. We're seeing an increased amount of ocular syphilis, and just recently I've seen increased amount of cardiovascular syphilis. So syphilis can involve any part of the eye. What you see down here is a case report from one of our faculty members at Emory that published this case a couple of years ago. It was a patient that got treated appropriately for syphilis 20 years ago, patient with well-controlled HIV infection that 20 years later came back with a new murmur, was found to have a huge ascending aortic aneurysm and had histologic evidence of prior syphilis. So again, think about the other manifestations outside the skin and the genital tract. The problem with syphilis, as you know, is that we don't have a point of care test, so we rely on serology. And we can either go with the traditional approach using a non-treponemal RPR followed by a treponemal test. However, in some instances, some states, some programs use a treponemal test, and each algorithm that you use can be sought with problems. So if you have somebody that presents with a primary ulcer, up to 30% of the time they can have a false negative RPR. Whereas with using the reverse sequence algorithm in a low prevalence population, you can have an increased amount of false positive tests. So some of these nuances with how to use the test, I would really refer you to the guidelines to go over some of that. But just to make you aware that this is not perfect, these tests are very challenging sometimes, and the presentations, as I just showed you, are very challenging. In congenital syphilis, which I mentioned is a problem, because of this increase we're seeing, and a number of new publications that have really come out talking about specific risk factors that place women at higher risk of acquiring syphilis. There's now the recommendation to retest pregnant women at 28 weeks and again in delivery if they have an increased risk of acquisition, listed there down below. And a lot of this is what I told you before about this intersection of sex and drugs. And then also thinking about the risk factors in the partner as well. So there's more detailed specific recommendations on syphilis and pregnancy that has markedly changed. But this is the main change here, is the triple testing in pregnancy. So what about treatment? Is what's still recommended for early syphilis? Well, do we have any data that giving more benzathine penicillin is going to enhance clinical outcomes or serological outcomes? And the answer is no, we don't. It's still recommended a single shot of benzathine in early syphilis, regardless of HIV infection, is what's recommended. There have been some observational studies that have tried to answer this 1 versus 3 question. There's an ongoing RCT right now that is attempting to answer this question. It's currently enrolling at multiple sites. I lift the NCT number there. That's trying to answer this question. So definitively, we have an answer versus 1 versus 3 shots of benzathine for early syphilis. What about penicillin alternatives? Are there any new data? We have a couple new studies looking at ceftriaxone. Recommendations would really be for prolonged therapy up to 10 days. We have limited data in Doxy, but the data we have shows that it looks like it's effective. So it is an option, but the data is more limited. And especially during COVID and benzathine penicillin shortages, people were trying to be creative and using amoxicillin and probenecid. We really don't have good data. There's really insufficient data. There is some folks looking at Ceftriaxone and trying to answer the question. We just don't have enough definitive data to make another alternative for you. And then for syphilis and pregnancy, there's some older data that a second shot may be beneficial. I'm going to switch gears from genital ulcer disease and move to urethritis and cervicitis. And what I have in bold are the most common organisms that cause non-gonococcal, that cause urethritis. The most common organisms that cause non-gonococcal urethritis are Chlamydia and Mycoplasma genitalium. Although trichomonas, especially of men who have sex with women, increased reports several years ago about Neisseria meningitidis, and then also reports of herpes and adenovirus, and most of the herpes is HSV1, not HSV2. So this comes up a lot. You have these multiplex tests that have come out. Should I test for Mycoplasma hominis or ureaplasma? So in the US guidelines, as well as the European guidelines, there's no rationale for testing for these. The data are conflicting. There's a recent publication looking at this in non-pregnant women that was just published in CID that again comes to the same conclusion. So there's really no recommendation to test for ureaplasma or mycoplasma on initial presentation or for persistent infection because we do not have consistent data. So what should you test for? Chlamydia and gonorrhea with either a vaginal swab for women or first catch urine for men. And the recommendation is not doxy or azithromycin, it's really doxy. And I'll go over that in depth when we talk about chlamydia and why that is, why that recommendation was made. For persistent or recurrent urethritis. We think about trichomonas in populations where trichomonas is prevalent, especially in men who have sex with women. And then Mycoplasma genitalium should be used for persistent or recurrent infection. For women, there's other abnormalities that can cause persistent cervicitis, including douching, dysplasia, and vaginal dysbiosis. So let's go into chlamydia to think about these differences between azithromycin and doxy and where this kind of came from. So what you see on your left is a compilation of studies that started to see a little indication in about 10 years ago that there might be a difference in efficacy between doxy and azithromycin for non-gonococcal urethritis. There was subsequently a meta-analysis that came out and that said, yes, that doxy looked a little better than azithro, both for urogenital and for symptomatic urethral infection. And then we started to get some observational data that showed retrospectively that doxy looked better from azithro, but we didn't have any RCTs. The other thing that came out was that there has been some reports that rectal infection is not uncommon in women that have cervical chlamydia. So can that be a problem? Can the rectal site serve as a reservoir for autoinoculation? So we got an indication from this study that looked initially, and this was again not an RCT, but we got an indication in women. If you look here at rectal chlamydia, the success rate was 78%, and for doxy 95%. For vaginal chlamydia, there was really little difference. And so really what happened was there's been 2 randomized trials now published, one in the US and one in Australia, basically looking at men who have asymptomatic chlamydial infection, showing a clear superiority of doxycycline over azithromycin for asymptomatic rectal chlamydial infection. And all this information together kind of led for the recommendation to change for chlamydia, as well to change for the recommendation for non-gonococcal urethritis, since chlamydia is the main cause of that. So again, when you think about what are the other lines of evidence? Is there any science behind this? So interesting, if you delve into the literature, there's actually colorectal and endocervical cell lines, which show a difference between azithromycin and doxy if you grow the organism in cell lines, showing that azithromycin, you need a higher MIC to eradicate the infection in a colorectal cell line than an endocervical cell line. There's differences, there's potential differences in the inflammatory response by anatomic site. And is this inflammatory response somewhat dampened in the rectum? And then there's several animal studies that demonstrate chlamydia in the intestinal tract is more difficult to clear with azithromycin versus doxy. So all this other evidence is kind of plausible, right? That there may be a difference. But then you'll say, well, what about adherence? What's this disconnect between adherence? And here I've got something that can be directly observed. And then I have to give my patient a 7-day therapy with doxycycline. So the problem here is that we don't know what the minimal effect of doxy is. I just showed you this dramatic data between the treatment efficacy data. And this has been thought about since 1999, when Julie Schachter wrote this wonderful editorial on this paradox, this compliance paradox. So we don't know what the minimal dose of doxy is that's needed to cure chlamydia. It's not well defined. But I give you some interesting pieces of data. One, there's an older study that shows that minocycline is very highly effective, just a single dose. There's a study that Laura Bachman did in 1999, which she looked at MEMCAPs versus self-report. And even though 16% of patients took doxy as prescribed for 7 days, the failure rate was 6%. And then there was this small little RCT that was done on 3 days versus 7 days of doxy in 77 women with cervicitis. And they did a test of cure at 3 weeks with a PCR showing similar success rates. So there is this disconnect. So we don't know what the minimal dose is. We just know that Doxy appears to be the better drug in all the data that I just showed you. So because of this, the chlamydia, the treatment was changed to doxycycline. So azithromycin is now an alternative. We have a concern, especially if you're going to give azithromycin for women. And it's not if there's a potential for auto inoculation of the rectum, showing you what I just showed you with problem with rectal effectiveness, that there may be a problem. So what's in the guidelines, if you choose to prescribe azithromycin, you should consider rectal testing in women after you treat the patient to make sure that infection is eradicated. We can't, the issue with doxycycline in pregnancy is an interesting question. I bring up 2 points. One is that if in pregnancy, what's recommended is azithromycin because of the potential concerns of doxy, and a test of cure is recommended 4 weeks after therapy. But there's been 3 meta-analyses that have looked at an association with macrolides and adverse outcomes in kids. And another thing to think about is if you think about tetracyclines in pregnancy, and these are 2 papers that talk about a lot of the older literature looking at tetracyclines is actually old. There's difference, again, pharmacologically between tetracyclines and doxy. And several of these authors thinks that these restrictions should really be softened, that the treatment effect of doxy is much different than tetracycline. More definitive data is needed, but some providers are prescribing to pregnant women and young children based on some of these recent reviews. So I give to you that information. That's the current that we have. That's the current information that we have. And that's the rationale for the change. This is just to showing you that some of the strains of chlamydia can cause lymphogranuloma venereum, can cause proctocolitis. This is an interesting gentleman that you see this, this large kind of tree-like circular lesion. This patient was thought to have a cancer, and they biopsied it 3 times, came back negative, was referred to me to say, what is this? I just did a swab for chlamydia, came back positive, sent the specimen for genotyping, and it came back as LGV L2B, gave him doxycycline, and that lesion completely went away. So again, think about presentations of lymphogranuloma venereum that may look tumor-like. Next, quickly, I'm going to move to gonorrhea and show you the important thing you need to know about gonorrhea. The rates are going up, just like with every other STD we talked about, but a couple of other points about gonorrhea. So disseminated gonorrhea has made a resurgence, and this is what you may have remembered about gonorrhea, is that it occurs very infrequently when it disseminates. Most of the older literature told us that it occurred in women around the time of menses. This is actually a foot from a pregnant woman I saw about a year ago, and was asked to see her for some other reason, and they were not aware that this was a manifestation of disseminated gonorrhea because nobody had seen it before. So the presentations that are most common are a monoarticular arthritis or a tenosynovitis polyarthralgia syndrome. Most of the time, the diagnosis can be made at asymptomatic mucosal sites. And disseminated gonorrhea has been associated with eculizumab, which inhibits complement, and there have been a number of DGI in people getting this particular biologic. But what I wanted to mention is that the epidemiology seems to be changing. What you see on your left is from an MMWR that came out last year, showing that the epidemiology is kind of more shifting in the current climate to men. This was associated with concurrent drug use with a lot of meth. And in my own backyard, we started to see an increased amount of disseminated gonorrhea, and talked to folks at CDC conducting the Emerging Infections Program, and kind of now have embedded surveillance, population-based surveillance for disseminated gonorrhea. This was the report. We had found 77 cases in the past number of years. Some of the epidemiology, again, complements what it was seen in Michigan, which is mostly male. And again, which is really interesting, is 30% of these individuals were over the age of 45. Most of them are having the similar presentations with either the septic arthritis or the tenosynovitis dermatitis syndrome. The exciting era of antimicrobial resistance just continues with gonorrhea. CDC has been monitoring antimicrobial resistance patterns for the past number of decades. And this is the data that kind of drives treatment recommendations. To look at this data, interpret it, and give you the best information that's available about antimicrobial resistance. So to get a little bit more granular here, remember about 10 years ago, dual therapy was recommended for gonorrhea. And the reason for that was there was a little bit of uptick in cephalosporin resistance, and the use of dual therapy really kind of brought that down a bit. But one of the consequences of that, you see, is the azithromycin MIC started creeping up. And because of that, because of the data we just saw, because of the impact on the microbiome, which I'll talk about in a second regarding Mycoplasma genitalium, the increased amount of azithromycin resistance in co-occurring enteric pathogens, the superior efficacy I just showed you of Doxy for rectal CT, and looking really granularly at the PK/PD, showing differences in the pharmacokinetics of the way these drugs work. The recommendations were made to increase the dose of ceftriaxone, not use azithromycin, and only use doxycycline for instances where chlamydia has not been ruled out. Most of the time, we're getting a combined nucleic acid amplification test, both for chlamydia and gonorrhea. So if you get both and your test for chlamydia is negative, you really just need to give ceftriaxone 500 or a gram in people that are over the 150 kilos. The other thing that was added was because most of where we think these antimicrobial resistance is taking place is the pharynx, recommending a test of cure 7 to 14 days after treatment. If you get it too close to 7, then you're more likely to get some dead DNA. If you get it closer to 14 days, you know, if the patient has recurrent sexual activity, you don't know if they've been reinfected. We don't know what the sweet spot is, but we think it's somewhere between 7 and 14 days. And there's 2 other investigational agents that are undergoing phase 3 clinical trials as we speak. So the other interesting thing is there's a proof of concept for looking at Bexsero, which is a group B meningococcal vaccine, which was licensed in the US in 2015. There was a number of years ago now in New Zealand, there was a outbreak of meninge B. Widespread vaccination led to a decrease in gonococcal incidence compared to chlamydia. And because of this finding, there's now an ongoing study looking to see if giving Bexsero vaccine versus a saline placebo will decrease the population incidence of gonococcal on a population basis. There's 3 enrolling sites in the US and the Department of Defense, as well as 2 sites in Thailand. And I list the NCT number for the study. So more to come on this, but pretty interesting data. Next, I want to turn very quickly to Mycoplasma genitalium. which causes about 25% of non-gonococcal urethritis. We have some emerging data and more data in women and its association with HIV acquisition. So the problem with this organism, again, the natural history is undefined. We don't really have any indication for population-based screening. So it's really recommended at this point for persistent urethritis and recurrent urethritis. And you can consider testing in those that have persistent cervicitis or PID. We have an FDA cleared NAT. So what the recommendation is for those individuals that have persistent infection that you use the test. And the reason for that is this. Treatment efficacy, we don't have a great strategy at this point for treatment. You can see azithromycin used to be effective. And it's really lost effectiveness over time. Doxycycline is about 30 to 40% effective. But what doxy will do is it will bring down the viral load. So the effectiveness is just really gone down. Moxifloxacin in the US is the only quinolone that works, but its effectiveness has waned as well. This is a study that was done in several STD clinics showing the high prevalence of macrolide resistance mutations. So azithromycin mutations are close to 60% in multiple cities. So how are we supposed to treat this? We don't even have a way to detect macrolide or quinolone resistance. So I'll show you what our colleagues have done in Australia. There is across in Australia and in some European countries, the ability to do a testing for macrolide resistance. So they took people that had symptomatic urethritis, cervicitis, and proctitis, empirically treated for doxy to decrease the organism load, because I showed you it's about 30% effective, then performed this test to detect Mycoplasma genitalium and resistance mutation, called the people back that had Mycoplasma genitalium, did the testing for resistance. Those that had macrolide resistance, they treated with the drug they had, ciprofloxacin, for that had macrolide resistance. If you didn't have macrolide resistance, they treated with azithromycin, and look at these cure rates. We don't have the opportunity to do that yet. We don't have the ability to do the resistance test. So what we've recommended in the treatment guidelines is if you don't have it available, you start with doxy and then you follow by moxy. In the instance that we do get resistance testing, this is the rationale to follow. There are some options, but they're limited. This is a really challenging pathogen to treat. So this is one of the many reasons why it's not recommended in the US to start from the get-go or to treat asymptomatic folks. You think about all the antibiotic exposure, and we really don't know if there's natural clearance. Some of the consequences are not well worked out, especially in men. Really, I'm coming to the end. I just wanted to share some important things just for the end that are new that you need to know about. There's a new trial that was published by Harold Weisenfeld in CID for a treatment trial looking at acute pelvic inflammatory disease. One of the things that we didn't quite know, we didn't have good data on, is should you add metronidazole up front to your beta-lactam and doxycycline? And this study said, yes, you should. So the change of recommendations now is that metronidazole should be added to ceftriaxone and doxycycline on the basis of this trial. And in this trial, there was really no data to support directing therapy against Mycoplasma genitalium. For bacterial vaginosis, a question we get a lot is, what do we do for recurrence? So a couple of things to mention. This section has really had a lot of new additions. One is the increasing data about vaginal dysbiosis as well as bacterial vaginosis leading to increase in HIV susceptibility. There's really no change in the recommended regimens. There's 3 new alternative regimens as single dose therapy, and they're listed in the text of the guidelines. Some really interesting stuff is these new agents under investigation, a biofilm disrupting agent, and Lactobacillus crispatus as an intravaginal agent to try to repopulate with healthier bacteria. For Trichomonas, there's a meta-analysis that has shown an association with preterm outcomes. But what's really, I think, new, there's advances in diagnostics, but what's really new here is the treatment recommendation from Patty Kissinger's paper that was published in Lancet Infectious Disease, showing that multi-dose therapy was more effective than single-dose therapy for treatment of trich. So recommendations in women now should include a week worth of metronidazole. We don't have any data in men for multi-dose therapy, so the 2-gram dose is still recommended. And there's been some more updates for those that have persistent infection with getting resistance testing and combination therapy. And again, you can get dead DNA from this organism up to 3 weeks, and it's important to get a repeat test in 3 months because of the increased risk of reinfection. A couple of things just to add about HPV. And just to make sure that you're aware of these data briefs that CDC publishes, which are quite interesting, comparing HPV-associated cancer in females and males. And we hear a lot of talk of anal cancer, but I wanted to show you in terms of the incidence by numbers, the rates of oropharyngeal cancer in males are very high, and to think about the importance of vaccination, especially for oropharyngeal acquisition of HPV. So a couple of really cool studies, these are older, but just really fascinating data looking at lifetime number of partners and increased prevalence of oral HPV. And the difference in terms of, I just showed you the difference between oropharyngeal cancer, but there's also some data that men have a higher risk of HPV, oral HPV acquisition and a lower clearance, and it's not explained by the number of partners, which is quite intriguing. So in terms of what I was going to show you that was new in the guidelines, which is really a nice table that was created, on looking at cervical cancer screening and comparing U.S. Public Service Task Force, ACOG, and American Cancer Society, where you've got all the recommendations in one table, which are really, really nice. Most of the recommendations for vaccines kind of align with ACIP. I mentioned the screening table, and then the annual cancer screening section really talks about the importance of at least annual, the digital anal rectal exam, and just wanted to bring to people's attention the recent press release from the results of the Anchor study showing the progression of cancer was reduced by removal of high-grade lesions in the anus. So more information for screening and vaccines available through CDC website and ACIP. And vaccines make a difference. And this just shows from the MMWR showing a decrease in HPV after the introduction of vaccines, a really nice MMWR. So to end with, then again, thinking about your sexually transmitted GI syndromes, proctitis, proctocolitis, enteritis, hepatitis A, B, and C, I'm sorry. That's really important. And then to assess for sexually transmitted empiric infections. A very nice paper that was published last year in the New England Journal talking about what you should do and how you should think about this. We've also had a new section on sexual assault talking about both male and female sexual assault. So I'm going to get right to the to the end and show you your questions and then get to your specific questions. But I wanted to give a thank out to all the people that I couldn't list all these people, their names. I just showed you their beautiful pictures that helped in the development of the guidelines. And thank you all for your input. Thank you for your slides and thank you for your knowledge. So let's end with this question. This was my ARS question. So this was the gentleman that presented with the perianal lesion. And to give you an update, what he ended up having was, so to remind you what you think about what you guys voted for to begin with, the issue is that he had more than one thing. And so he was treated empirically for primary syphilis. His HSV PCR was negative. His initial RPR was negative. As I mentioned, the issue regarding the negative test, he actually had a positive EIA. His repeat RPR 2 weeks later was 1 to 32. He had rectal chlamydia. I actually did a swab of this lesion and this was sent to CDC and this was confirmed as LGV. And he also had acute hepatitis C. So he had several STIs at the same time. So the post-test question 1. So let's pull up the poll in terms of what you guys voted for. I know what you said pre-test. What is the answer to the question with this woman that had a vaginal chlamydial test and what was the correct response? So if you can look and see what the correct response was regarding the management of this woman that had chlamydia. So if you would vote, and let's see if you've increased your knowledge base. I don't see the result of the poll coming up. Oh, there it is. Okay, so the correct answer, most of you got, which is great. Repeat testing is recommended regardless of whether her partners were treated or not. That is correct. And which of the following is true regarding the etiology of persistent NGU? So we talked about trichomonas, Neisseria meningitidis, herpes, the association with Lepotrichia and Snethia and Mycoplasma genitalium. And this was kind of, we talked about all these things throughout the presentation, but this is really thinking about the nuances of making this diagnosis of persistent urethritis and the data that we have. So this is a lot of information and multiple places during the presentation we talked about these things. So interesting to see what you are going to give me in terms of recommendations. So very interesting. The correct answer is Neisseria meningitidis. So as I mentioned before, we don't have any long-term data on Mycoplasma genitalium urethritis in terms of the outcomes, reproductive outcomes. So the correct answer is actually, what is correct is Neisseria meningitidis has a similar colony morphology and cannot be distinguished between Neisseria gonorrhea and gram stain. So the trichomonas is more common in men who have sex with women. HSV1 is more common than HSV2. That was a little bit more challenging question, but the correct answer was Neisseria meningitidis. So that is, I am done with my presentation and I'm willing to take questions I can answer on the chat. So the first question from Daniel isn't urethral rectal pharyngeal screening just easier, and doesn't pharyngeal chlamydia pose a risk of yes. So the issue is why the recommendation for only GC pharyngally. So yes, there is, you can pass that pharyngally if you have chlamydia in your throat. Yes, you can. The issue is we don't know as much about the natural history about chlamydia. There is some chlamydia that can spontaneously regress. We just don't know about the natural history. And we're more concerned about it because for gonorrhea, because that's where we think the incubator, that antimicrobial resistance is occurring. Now, we know you're going to get it because most people are getting chlamydia and gonorrhea testing in the throat. So the reason is just more that we don't have much data in terms of the natural history of chlamydia in the throat. So of course, if you see it on a positive test, you're going to treat it, but that's why there's a difference. Jeanette asked me, why don't you have screening recommendations for chlamydia in young men? All those women are getting it from somewhere. That is correct. So when you're looking at a population-based and you're trying to think about who has the reproductive health consequences of infection, it's the women. So the targeting has been directed at women because we have data that shows that screening in women leads to decreased reproductive health outcomes. That's why what is said, where the screening kind of nuance comes with, if you've got populations that are at high risk, including STD clinics, adolescent clinics, you can very much do what you want based on the local prevalence. But that is why in a population-based, that is on the population basis kind of where we are. That's why there's a difference. Tony asked me, where are we with Hsv vaccine development? So we've had several failed kind of vaccine attempts with herpes. There is another vaccine trial that is in development by several companies for herpes. So we just haven't been able to figure out in terms of correlates of protection. And so that's why we don't have a vaccine. It's been very challenging. Peter asked me, when an individual has chlamydia or gonorrhea, how long after that contact is not accurate enough that treatment for the contact is not indicated? So that's a great question, because right now what we have recommendations for is treating the epicontact. And so the question really is, should we really be doing that? And it's a way basically for STD control, right, is to treat the epicontacts. But there's not 100% transmissibility. And if you've got somebody that's comes in and is a contact and you test them and they're negative, it really kind of gets difficult because it depends when the sexual exposure was. So it gets kind of difficult. And so that's why the recommendations are to kind of epi-treat. But there's been questions in the literature about whether that's really true. Your other question about duration of shedding. Some of the older literature we have is the duration of shedding for gonorrhea is 7 to 14 days, as I mentioned. Most of it's really gone within 7 days. For chlamydia, however, we have data it can last for 3 weeks with dead DNA because it's more cell associated. And so that's why the recommendation is in pregnancy to retest at 4 weeks. Okay, so if a patient tests positive at 14 days post-treatment for pharyngeal gonorrhea, what can you treat? So the issue is, again, you have to make the decision, is this treatment failure? Is this reinfection? And so what we normally do is we have to bring the patient back in, perform another nucleic acid amplification test because it's more sensitive, then do a culture, then get a history to see if have they had intermittent contact. If it is if it is reinfection, most reinfections can be cured with the same dose of ceftriaxone, the 500 milligrams. So I would refer you to the verbiage and the treatment guidelines that talk about that particular scenario, but you have to make sure you know where to get a culture. Most of you don't have availability of culture, so think about that. Where could I get a culture? Either an academic center, your state or local health departments. Jeanette asked me about comments about anal Paps. So I would look at the recommendation that's in the guidelines. I know there are some societies and some states that recommend anal Pap smears. There's no national recommendations for anal Pap smears, because you really have to have, if you're going to perform it and it's positive, what are you going to do with the results? Do you have the ability to do high resolution anoscopy? Do we have a program that's going to follow patients? So the point is, if you are going to do it, what are you going to do if your patient has a positive test? Do you have HRA that you can do? If you do have HRA, do you have providers that are going to treat and they're going to follow the patient longitudinally? So you have to kind of think down the line. Devika, are there any new agents on the horizon for trichomonas treatment for patients having difficulty tolerating nitroimidazoles? So the short answer is no. Trick is kind of the neglected STI. Nobody really cares about it. And what we're doing in instances where they can't tolerate it is we have intravaginal therapies that we can use. However, they are less than 50% effective. What you see in the treatment guidelines, there are some recommendations for how to do this. You can also contact me directly if we need help with individual patients. I assist CDC in helping with patients that have resistant trichomonas recalcitrant infections. One of the things that we found useful, but we don't know how long to use for what duration, is boric acid, vaginal suppositories. Angela asks, we've had several people over the age of 45 who asked for HPV vaccines. How do we approach this conversation? So again, what ACIP says and what's in the guidelines is basically it's a shared decision-making, that's what the wording is. And so you and the patient need to talk about shared decision-making about risk. And it's very easy to get the vaccine if you both feel that your patient should be able to get the vaccine. I would refer you to the language on the ACIP website, or there's also in the treatment guidelines regarding that. Screening chlamydia and gonorrhea for women, could you explain to use vaginal swab? Okay. So for women, going back to the CDC 2014 guidance, the preferred specimen is actually a self-collected vaginal swab. And the urine, if you look at sensitivity and specificity, going back to that 24 guidance, the urine has sometimes some inhibitors in it, so the sensitivity is a little bit less than doing a vaginal swab. And self-collected swabs by women are just as good as a clinician swab. Could you use first? So I think you just got to get used to it. Women that use tampons have no problem with doing a swab. They go to the bathroom and they can put a swab up as easy as they can pee in a cup. So it's just, you can change your practice. It's actually very simple. So Eva asks, what's the recommendation for rectal Mycoplasma genitalium detection in asymptomatic patients? So again, I mentioned there is no recommendation for testing for MGent in asymptomatic patients. We don't know the natural history. We know MGent can cause a problem, but there's no recommendation for testing in asymptomatic patients. It's the natural history, it's the treatment problems. So you can consider testing in instances where patients don't get cured with recommended therapy. Do you anticipate changes in the HRSA coverage of follow-up for positive anal Paps based on the anchor study? I can't answer that question. I really don't know. We haven't seen, we just got a press release. So we'd like to see the data before we can make those kind of recommendations, as you know, because there are no national recommendations for anal screening. Can syphilis be passed through deep kissing? Great question. Yes, there was a study in MMWR that was done a number of years ago that showed only oral transmission. So yes, only oral transmission can happen through penetrative activity, determining whether it's what goes in the mouth, whether it's a foreign body, whether it's a body part, whether it's just a tongue. That hasn't been really well worked out, but yes, you can get it through oral genital contact. If you participate in rimming and things like that, where there's potential contact with the anus or perianus, you can understand that there can be some potential contact. Is anybody looking at a better test for syphilis? Lisa asked me, hope for the future. Yes, we're trying. So one of the things that you may be aware of is oral swab testing. So there's some interesting data looking at oral swabs, and we're particularly looking at it in extragenital locations because syphilis is disseminated. So more to come on that. It's kind of really cool. There are new serologic tests that are being looked at, but the serologic tests we have are decades old. Todd is asking, any recommendations for home self-testing? So there are recommendations. I Want the Kit is a wonderful self-testing kit that Charlotte Gatos has been running at Hopkins, where you can just Google that and you can do your own self-testing. So there are reputable options for home STI testing. Lazidrask, if somebody who is reactive with syphilis and one-to-one previous tests are non-reactive, denies history of syphilis, test to retest. So yes, we see this. Sometimes somebody that's had previous syphilis goes non-reactive, then again, one-to-one, you're going to have to use your best judgment there. If they've been sexually active with somebody and you do a very thorough exam, can't find anything, what I usually do in that instance is bring them back in 2 to 3 weeks. Tell me, have them look for anything, but have them bring them back in 2 to 3 weeks and repeat that test. For Mycoplasma genitalium, do you recommend asymptomatic partner? So a patient that has is symptomatic with M. genitalium, yes, there is recommendation in the guidelines for partner management and somebody that's got symptomatic M. gent. Next question. On that same note, what do you do for true allergy? And for trick. So a nitroimidazole true allergy. So you can, your options include desensitization or intravaginal products. So there's 2 intravaginal products that we use. One is intravaginal paromomycin, which has to be made through a compounding pharmacy. This is based on a publication of one paper that came out in 1997. And the compounding information is found in that paper by Paul Nerjeski. Or you can use boric acid, or you can desensitize. Yes, you can contact me about a case anytime that you want, and I think you can get my contact information should be available through IAS USA. Could you comment on self-collected rectal and pharyngeal swabs? Versus patients know what they're doing. Hi, Emily. Yes, patients know what they're doing by self-collecting. So what you can do is that there are available pamphlets that you can put in bathrooms for teaching. It's very simple and just showing patients, and a lot of patients find it very acceptable to do self-collected testing. And it's just as efficacious as clinician samples. What are your thoughts on rectal ureaplasma? So again, ureaplasma, Mycoplasma hominis, in my mind, doesn't have a place at this point. The data is conflicting. I know that some tests are available, but we really don't have good data at all that it makes a difference at all. And the other thing is we don't know the best treatments to use. Tetracyclines are becoming the organism is becoming increasingly resistant. So there are no recommendations in the US guidelines and the European guidelines to test for ureaplasma or Mycoplasma hominis. Frequency of follow-up RPR post-treatment in HIV positive men, 3 months, Jeffrey. So 3, 6, 12 is what you should do. That's per the guidelines. What is the current recommended timing for test of cure after treatment of syphilis? What is if the titer doesn't decline? That's Lynn. So that issue is really what you'll see, the nuance, which I didn't get a chance to talk about in the syphilis guidelines, is that the titer, the decline for primary, secondary, and early latent may take up to a year. Before it used to be 6 to 12 months. We know that now it can be longer. And so now the recommendation is at least a 4-fold titer drop within 12 months. The difficulty is there are some people whose titers don't drop and we don't know why. So again, you're going to have to use your judgment. There is some language in the guidelines about kind of what to do. I've had a lot of people contact me with titers that were 1 to 128, 1 to 256, and they just didn't move. And sometimes, you know, are you treating the test or are you treating the patient? So in difficult things, talk to an expert and just get a second opinion. Jeanette, what is the best screening algorithm for pregnant women taking into it? So again, you have to think about your state and whether you start with a treponemal test or you start with an RPR. So to help you with your question, Jeanette, what I would recommend is that you go to the treatment guidelines because we have an answer to your question, which talks about how do you do that in instances where you need to retest a patient and you get discordant results. So that's a very complicated question, but I think it would be answered if you look in the guidelines. Yes, for syphilis screening, either you're using a treponemal test or you're using a non-treponemal test. What about metronidazole? Stevens asked me, what about metronidazole and ethanol? Yes. So we did a deep dive on that, which was kind of cool, right? Because that was, that's kind of been in the label for a long period of time. So we did a deep dive and couldn't find any really good evidence about that. That's why it was taken out of the guidelines. So that's been taken out, this 24 hours of waiting. Megan is asking, how common are false positive serologic test results? So it depends on the prevalence of syphilis in the population. It's really a challenging question to ask. So you have to think about the population that you're screening and the pros and cons of using the test that you're using. So in pregnant women, normal population-based screening, you're going to more likely have a false positive test by using a treponemal-based algorithm. And I think I did all those questions. Let me see. I don't see any other questions in the chat. So wanted to thank everybody else for sticking with me. And I think I answered all your questions, and thank you so much.
Thank you, Dr. Workowski. As a reminder to our audience, evaluation and how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast. If you're interested in additional webinars on STIs, in November 2nd, we have a webinar on syphilis hosted by Dr. Ganem from Johns Hopkins University. And for other list of upcoming webinars and how to register, please visit the IAS USA website. We have an upcoming COVID-19 dialogue that will discuss COVID-19 vaccines this Friday, October 22nd. And to register for our upcoming courses, please visit the IAS USA website. Again, we'd like to thank our presenter, Dr. Workowski, and to the audience for your participation. This concludes today's program.